It is a pleasure to be back and see a lot of old friends. I guess old actually is an operative word in some cases. And, some of my friends were on the staff here when I came to do a fellowship, so I appreciate the opportunities they gave me. The other thing that's interesting about coming back here and talking about atrial fibrillation is how important this institution has been in how we manage atrial fibrillation, and whether it has to do with some of the risk stratification work that Brian Gage did, or whether it is the understanding of, or at least attempts to understand, the physiology of atrial fibrillation that Jim Cox and Rick Schuessler and John Bueno did, which led to the Maze operation. I remember one day John Bueno and Jim called me to Jim's office, and they were trying to explain this operation, and I was highly skeptical, and of course we saw a lot of AFib early after the procedure, so I didn't think it was going to work. But you know, it's revolutionized how we take care of things, and from that have evolved the other techniques that we use. Now, in going through things today, I'm not going to show a lot of intracardiac electrograms, so don't worry about that. Well, maybe just a little bit. But we'll focus on some broader issues. And by way of disclosure, some of the topics I'll talk about, there's a Topera mapping system, and I'm on the Abbott Scientific Advisory Board, Biosense Webster Advisory Board, and Medtronic Strategic Advisory Board, and they brought up Cardio Insight, which is another matter that we'll talk about. Now, for the big picture of atrial fibrillation, you all deal with this every day, and you know that it's the most common arrhythmia we deal with. It affects more than 2 million Americans, preferentially the elderly, but we see a broad range of ages. It's expected to increase 2.5-fold by 2050, and the risk of developing atrial fibrillation over your lifespan, once you're over the age of 40, is about 1 in 4. So it's about comparable to cancer. And so looking around the room, some of you either already have it or will get it, so you better listen up. This is a projected number of adults with atrial fibrillation. You can see how that curve climbs. It's not necessarily a stock you'd want to buy, but nonetheless, it's going to be a clear increase. And so when you start planning about how you have to deal with this, you have to take that into consideration. The age-related incidence of atrial fibrillation affects both people with chronic and paroxysmal atrial fibrillation. And you can always tell when slides are old because the terminology keeps changing. We no longer call it transient, we no longer call it chronic, but basically the principles are still the same. And that's true for both men and women. Now, for a long time, and when you look at the Framingham data, for example, that's really flawed data in the sense that it was based on some random ECGs where they picked up atrial fibrillation. But what's been interesting with pacemakers and defibrillators, they become very sophisticated, and they can tell you whether people have had atrial fibrillation, and they can tell you the number of minutes people have had atrial fibrillation. So you can quantitate the burden of atrial fibrillation. And from that, we can look at the distribution of atrial fibrillation and compare it to what our clinical assessments may be. So if you had asked people to look at the burden of atrial fibrillation that people had and say, well, is it paroxysmal or persistent, this is basically what they came up with based on ECGs and other kinds of monitoring they did. But then if you look at the limitations of classifying AF, on the left-hand panel is the clinical impression. And on the x-axis is the AF burden. That is the percent of time people are spending in atrial fibrillation. And you would have guessed, based on the clinical impression, that the majority of this was paroxysmal. The reality when you interrogate a device is that a lot of it is persistent. And so and by persistent, that's defined as more than 7 days. So the trouble with the definition of persistent is it can mean 7 days to a year, which includes a lot of patients, and that has some implications. But in any case, we underestimate it. So why is the incidence of atrial fibrillation increasing? Probably foremost is that people are living longer, and it's an age-related phenomenon. Hypertension, I think, is important. We treat that more effectively than we once did, but not everybody gets good care for that. People live longer with heart disease, and so they get more heart failure, myocardial infarctions, valve disease. We may not have as much rheumatic valve disease, but if you're living longer and you get a stretched annulus, you get more mitral regurgitation, all these things contribute. I think obesity is important, sleep apnea, and we're monitoring people more, so we're going to diagnose it more because we'll see it more. If you look at the effect of weight, this shows a cumulative hazard of developing AF by the baseline BMI. And you can see that for people who are obese, especially for men, they tend to develop more atrial fibrillation than those who have a normal habitus. There was a program that was reported in which they made great efforts to get people to exercise, diet, lose weight, and they were able to successfully decrease waist circumference and BMI. So if you can get people engaged in this, it is feasible to do. And these were the changes in the symptoms scale. On the left-hand panel is the burden of atrial fibrillation, and on the right-hand panel is the severity of symptoms. And what's interesting about that is they reduced the burden of atrial fibrillation by about 50%. Doesn't mean people didn't have any, doesn't mean they were cured, but they had less. And even among the people who had atrial fibrillation, they had fewer symptoms, probably because you don't have to lug, an extra 150 pounds around. You're going to be able to tolerate it better. What about symptoms and other things? Well, I forgot to mention, this is about alcohol consumption. So, a lot of our patients like to drink alcohol, and some are moderate, others are not. But this is a study of the effect of alcohol and the amount people consume and how that affected their propensity to atrial fibrillation. And as you can see, the more alcohol you drink, you tend to get more atrial fibrillation, at least at the higher range. And so you can counsel your patients to cut back on the amount of alcohol. I don't tell them they have to be teetotalers, but there are people who even one glass will put them into atrial fibrillation. So I advise them to, just drink one glass of wine. And of course, their response to that usually is go out and find the biggest glass they can possibly find. So you have to be careful as to how you advise people. Now, what is critical is the mortality related to atrial fibrillation. And when you look at the Framingham data, it's clear that for men and women, younger and older, the mortality with atrial fibrillation is higher. And some of this is related to comorbidities. Some of it probably is inherently related to the atrial fibrillation. What is also kind of interesting to me is we often have this question of which comes first, heart failure or atrial fibrillation? And the answer is yes. So if you look at the left-hand panel, those were patients who had atrial fibrillation and developed heart failure. And on the right-hand panel, those were people who had heart failure and developed atrial fibrillation. And you can see the curves, they're very similar. So it's a little bit hard to differentiate those two. And where that's important is that many times if you can get people back into a normal rhythm, their heart failure will improve or their mitral regurgitation will improve. So it's worth those efforts. These are the adjusted probabilities of death, stroke, or systemic embolization according to the type of atrial fibrillation. And so sometimes the question occurs is, well, does it matter whether it's paroxysmal as opposed to permanent atrial fibrillation? It's clear that people who have permanent atrial fibrillation have higher event rates, and it's worse in both cases if you have pre-existing heart failure. Now, another thing to bear in mind is the progression of atrial fibrillation. So in this panel, if you look at year one, you see in orange the people who had sustained atrial fibrillation. The yellow is recurrent atrial fibrillation. And then as you sweep across, you'll see that those numbers get bigger. So it's fair to say that over time, the proportion of people who have atrial fibrillation and have more of it grows. But when you look at some of the data like Framingham and things like that, it's hard to tell that unless you do a sub-analysis of the data. But that, I think, has an influence on their outcomes. If you look at the mortality with recurrent atrial fibrillation, in this figure, on the left-hand panel is the incidence of stroke, in the middle is heart failure, and on the right is mortality. And mortality and heart failure were higher with recurrent or sustained atrial fibrillation, though the stroke risk did not differ. And that leads to some interesting questions as to how much atrial fibrillation you need to have a stroke, and we'll get to that. And what about the symptoms related to atrial fibrillation? So in this survey of patients, they determined that about 38% were asymptomatic, 46% were classified as mild, though honestly, when you look at their criteria for it, I would have said it's really more mild to moderate. And I think one of the mistakes people make in managing atrial fibrillation is they tell people not to worry about it. Well, that's fine if you don't have atrial fibrillation, but if it's affecting your quality of life, you need to be more attentive to how to treat it. And about 16% were very severe and disabling. And that tends to be a lot of the patients that those of us in electrophysiology see by nature of the referral patterns. However, if you look at the association between symptoms and outcomes and look at this, it doesn't predict death or stroke. It did have some statistical significance on hospitalizations and bleeding complications, but you can't tell patients if they're not asymptomatic that it's not going to affect their risk of mortality or their stroke risk. This is the 5-year survival after AF-related stroke. It's not good. I've seen cancer curves that don't look better than this. And so I think that we have to take this seriously. The risk of mortality after stroke is worse in people who have a high CHA2DS2-VASc score because of all their comorbidities. But the good news is that if you look at 5-year survival outcome with appropriate oral anticoagulation, it does make a difference. Now, where that I think is important is that recently, this has been emphasized a lot in the literature, and this is a study in which what they did is they looked at the prescriptions for oral anticoagulation and found that with the new guidelines that are coming out, it is having an impact on how people practice medicine. So I think that's progress. We're not where we need to be yet, but we're getting there. So I raised the question of how much atrial fibrillation is enough to have a stroke. Well, this is where the device data comes in handy because the pacemakers and defibrillators can allow us to track that. And in the TREND study, one of the things they were looking at was thromboembolic rates according to the burden of atrial fibrillation. And so if people didn't have atrial fibrillation, the risk, of course, was low. If it was just a small amount, less than 5.5 hours, it was low. But where they began to see an increase in the unadjusted data was more than 5.5 hours. And then if they adjusted it for risk, it still shows that the risk of an embolic complication is higher in that group. So probably, though we've taught 24 hours roughly, it may be more down in a lower range. And it actually gets more complicated than that. Because if you then do a sub-study or analysis of the patients in this trial who had strokes, and there were 40 of them, some interesting data pops out, and that is that atrial fibrillation was detected prior to stroke in only half of the patients. So they had it, but just half. So if you look at this bar graph on the left, which is kind of a complicated figure, the gray shows periods of atrial fibrillation, the dark part is the amount of time in that time segment that they were in atrial fibrillation, and the red line is the reference point from when they had the stroke. Now, 45% had no atrial fibrillation within 30 days prior to stroke, and 70% of the patients with AF were not in AF at the time the stroke occurred. So the idea that stroke is related to AF is valid, but trying to pinpoint exactly how this plays into subsequent events requires further study. Another study called the ASSERT trial looked at subclinical atrial fibrillation and the risk of stroke. First of all, they looked at subclinical arrhythmias detected by the devices and compare that to the detection of them clinically, meaning did people see them on electrocardiograms or monitoring, were they aware that this was going on? And basically, if they had subclinical tachycardias, it's more likely that you would have picked up on this clinically, but not necessarily. And if they didn't have any, then of course that incidence would be quite low. What about the relationship to atrial fibrillation and stroke? Well, same thing, is that if they had subclinical clinical atrial tachycardias, it's more likely that they were going to get ischemic stroke or systemic embolization. Now, what's interesting about that data is that while the risk increases with the time duration of atrial fibrillation, it begins at 6 minutes. 6 minutes. So what do we do with these patients when we interrogate the device and they've got 5, 10, 15 minutes of atrial fibrillation? Well, that requires further study, and there are trials in progress on this. The question is, do we need to treat it more aggressively, either to suppress the atrial fibrillation, which would make sense if we had good treatments, but the treatments we have are not great, or would anticoagulation reduce the stroke risk? And there are trials in progress for that. Then there's left atrial appendage occlusion, and the team here has been doing this in one form or another. As you know, the Watchman is positioned in the left atrial appendage using a transeptal approach. When you look at the national coverage decision, this right now, it's a CHA2DS2-VASc score of greater than 3 or greater, or a CHA2DS2 equal or greater than 2. They have to have a history of major bleeding with anticoagulation, unable to maintain a stable INR, or a high risk of bleeding. So, for example, a friend of mine loves to play ice hockey. He has AF, and he's anticoagulated. He's not going to give up ice hockey. So should he stay on a NOAC, or should he have one of these devices implanted? Well, that's debatable. I'm not sure the insurance companies would pay for it. They might tell him to stop playing hockey. But those are some of the decisions we'll have to make. As we look at the safety events with the Watchman, you can see that in this series of trials, as people get more experience putting them in, the complication rates go down. And then if we look at a comparison of 3 trials, the incidence of pericarditis, the success rate, first of all, goes up. And some of that is related to proper sizing and understanding which these devices come in different sizes, and you have to fit it to the appendage. And there is experience gained with that. So we put in about 100 of them, and I think the guys who put them in really have learned a lot over that process. Pericardial effusions have gone down. The need for surgery has gone down, though interestingly the embolization rate hasn't changed. If you look at this meta-analysis, you can see that with the Watchman, the ischemic stroke risk actually is not as good with the Watchman as it is with anticoagulation. However, the bleeding risk or hemorrhagic stroke is lower, disabling strokes are lower, so in the balance, the bottom line is it compared favorably. And then in taking care of patients afterwards, right now we're typically putting people on warfarin for 6 weeks, then dual antiplatelet therapy, and eventually aspirin. But there are some protocols evolving that potentially would use NOACs or just use the dual antiplatelet therapy. One of the things that we looked at and published recently was we took the highest risk patients, people with neurological injuries or GI bleeds, who ultimately went through a Watchman, and we put them on warfarin for that 6 weeks period of time, and there were no bad outcomes from that. So you can put people back on these drugs for a limited period. Now, there's an economic cost to atrial fibrillation. It affects health, quality of life, ability to work. It causes heart failure and stroke in some instances. And the medical expenditures for it are about 1% of the healthcare budgets in the United Kingdom and France, and about over $6 billion in the United States. When you look at how this is distributed, and this may have some strategic importance to us as we think about how to bundle care, hospitalization is the key part of it, but it's also related to treating comorbid conditions. Maybe some of those could be treated more effectively. Outpatient care is important. I thought medicines would be a higher percentage, but actually it's smaller in that analysis. The costs increase with recurrence of atrial fibrillation, and you can see here, if you look towards the right on the panel, that the amount of hospital costs go up as people have more and more atrial fibrillation. So if we found a way to cut down on that, we could impact the cost. And then in this analysis of a privately insured population, probably healthier than most, if you work your way down to the bottom, what you see is that the annual cost was about $18,000 if you had atrial fibrillation, over $3,000 if you didn't. Difference is about $15,000. So this has a big importance to insurers. So that's why they're coming to us and say, what can we do to get these costs down? Now, the strategies for cost containment, rate control in this European study was the cheapest, rhythm control more expensive, and the determinants of cost had to do with cardioversions and hospitalizations, anesthesia charges, cardiologist charges, and frankly the low efficacy of antiarrhythmic drugs. So the dilemma we're faced with is rate control is cheaper and simpler, but it's not tolerated by a lot of patients. Rhythm control may improve quality of life. Catheter ablation and the maze are curative in selected patients, but the initial costs are high. It may reduce the long-term costs. I think it's particularly for certain patients it would. But the cost benefit will depend on the improved results and lower risk of complications. And in this analysis, the total charges for a procedure are typically more than $50,000, probably actually more up around $70,000. And so if you had patients that are about 65 and you had an 80% success rate, which is pretty good. We might get that at a good center with paroxysmal AF, but not with persistent. Then the relative risk of stroke after catheter would need to decrease by greater than 42% compared with anticoagulated patients for the ICER, which is the incremental cost effectiveness ratio. So it's a way of looking at cost and quality of life to be less than 50,000, which is kind of the mark that is used to judge this. So we have a ways to go, I think, is the bottom line of making this truly a cost-effective therapy. Now, only a minority of patients nationwide get an ablation for atrial fibrillation. And the good news on this is that when you look at who gets them, they're younger, they have less comorbidity, they're more symptomatic, they have a higher burden of previous antiarrhythmic drug therapy, and seldom had permanent or newly diagnosed AF. So I think people are choosing carefully in who they do these procedures on, though I think there is a shift moving towards doing AF ablations earlier because it tends to be, particularly for paroxysmal atrial fibrillation, it's more effective than medicines. And our data shows that it improves outcomes. Now, one of the things we're going to have to deal with is MACRA. And so if you think about where we are now with what I refer to as meaningless abuse, you know, you're clicking away on your electronic medical records and all this stuff that doesn't make much sense. Well, it's going to get worse. This is like that on steroids. And so, whereas in the past, mostly what we had to do is document that we had done things, here we're going to actually have to get some results. And one of the things they're going to ask for is models to bundle care and get costs down. And we're going to have to look at how we could potentially bundle this and not go broke in the process. It will be sort of a shared risk, but we're not going to be able to just say no. Now, is there any hope for new drugs? Well, not much. There has been some work combining ranolazine with dronedarone, but like many drug studies, it shows that the cumulative effect is better than either drug alone. It does reduce the burden of atrial fibrillation, and this is usually how drug studies are written. But there are no group differences in the development of persistent atrial fibrillation, cardioversions, or the amount of time people spend in more than 5.5 hours in atrial fibrillation. And the freedom from AF is not reported. So, I mean, I have tried this approach, and it's just anecdotal, but I haven't found it very useful. But it is something to keep in mind. It might be beneficial to some patients. There's a medicine which I believe is called vanoxarine. I think that's the pronunciation, which is a combined calcium, sodium, potassium, sodium, and late calcium channel blocker, and affects the QT interval. And it can come in an oral formulation, and if you give this to people, it has pretty good conversion rates. So that's something to keep an eye on. What about implantable atrial defibrillators? Well, years ago, when Joe Smith was here, we had a protocol where we put in these atrial defibrillators, and the patients hated them because it turns out that a 1 or 2 joule shock hurts, and they don't like getting shocked repeatedly. So that idea was abandoned. However, there's some very interesting work that Igor Efimov did when he was here, in which he used these sequential pulses, and it dramatically reduced the energy required to defibrillate the atria, down in the order of 0.02 joules. Well, that's something that people would tolerate. So I can see where if this continues to evolve, and I think that there is a major company looking at it, that this notion might come back. These just show the mean energies for defibrillation of the atria. Now, looking at approaches for ablation of atrial fibrillation, as you think about how electrophysiology has evolved, it really has depended on our ability to understand physiology. So when I was a fellow, we studied physiology. Beyond that, we didn't do much. In fact, I was at a poster one time, and an interventional guy that I knew when I was a resident in Michigan, a friend of mine, he came up to me and asked me what I was doing, and I said, well, I went into electrophysiology. And there was this silence, and it was Eric Bates, actually. And Eric looks at me and he says, you guys are the neurologists of cardiology. Well, he was right. But from that, we began to understand physiology, and whether it was AV node reentry or some of the atrial tachycardias that we ablate, flutter, all these things, it was all based on understanding physiology. Now, the challenge we have with atrial fibrillation is you can go back to the 1800s, actually, where people argued about whether it was a focal mechanism, multiple focal mechanisms, or some sort of reentry. Some of the speculation was if you could just chop up the atria in enough pieces, eventually you could get rid of the atrial fibrillation. And arguably that's sort of what the Mays operation did. But bear in mind, Jim Cox spent 10 years working on that model before he did it in a human. And so he had the idea that if you could block reentry, you could block atrial fibrillation. And I don't know if Rick Schuster was in the crowd. He would have a lot of insight into this. But my understanding in talking to John Bueno was John thought that there actually were some fixed rotors in the atria and that they would be spinning around and the wavefronts would spread out and look fibrillatory. And if you could identify where those were, interrupt them, you could prevent atrial fibrillation. But they looked for it, and they didn't find it. They found some repetitive wavelets, but that's about it. Al Waldo, who's up at Case Western in Cleveland, has devoted a lot of his career to this. And he has these epicardial mapping systems in which they've recorded up to 500 electrodes. And he's not seeing fixed rotors. In fact, he's seeing a jumble of mechanisms. So this is a complicated physiology that we still don't fully understand. But I think an important development is the work that actually started at Case when Yoram was up there. Charu Ramanathan was up there at that point. They published this in Nature back in 2004. And then he got recruited down to Washington University, and it was there that I had some conversations with him, and I remember talking to Phil Kukulich and saying, Phil, this might really have some potential. And, Phil really took charge of this and ran that project. And I'll comment on his data in a moment. But it's a system in which there's a vest that is applied to the patient, has all these electrodes embedded on it. You put them through a CT scan, and then it registers the epicardial signals to the heart. And through a complex mathematical formula called the inverse solution, it reconstructs epicardial activation. So we did some initial work on this in some focal atrial tachycardias and wolves and things like that, where you could pretty much pinpoint where something was coming from and see how accurate it was. And then about the time I was moving to Cleveland, Phil worked with them on this for atrial fibrillation. And when they tried to reconstruct these maps, I'm not going to go through a bunch of movies and things, but the bottom line is you could see these sort of complex, if you want to call them rotors or repetitive wavelets that would break into different fronts. And as they looked at the complexity of this, it depended on whether it was paroxysmal, persistent, or long-standing persistent. And I think where that becomes important is that if we're just going to design one way of approaching atrial fibrillation, the approach will be different for people who have paroxysmal as opposed to more persistent atrial fibrillation. And there may be some patients that are just incurable, at least with catheter-based techniques. Though I must say that the Maze operation included some people who had been in atrial fibrillation for years, and it actually did work. So I do think that there is a possibility that as some of our technologies evolve, we'll be able to tackle that more successfully. Hasegaer, so what happened with this is that there's a spin-off company called Cardio Insight that was based up in Cleveland, and they came to me and said, can we develop this here? And we started working on it, but it was slow, and they ran into all sort of impediments for the FDA. And I encouraged them to go work with the group in Bordeaux, France, which is Hasegaer's group, a very good group. And they really pushed this along. And so they started looking at phase maps of atrial fibrillation showing intermittent reentry or repetitive wavelets. And the mean number of drivers varied depending on how persistent the atrial fibrillation was. So as you might imagine, the longer people have been in atrial fibrillation, the more complex these things come. And as they would target these, they were able to convert more people to atrial fibrillation. That seemed to have a better outcome. And the freedom from atrial fibrillation at 1 year was 85%. Now, none of the catheter-based procedures hold up at that number over the long term. There's always a certain amount of recurrence that occurs over the time, but nonetheless, that's pretty good. Now, from there, there's the AFACC trial, which used the same technology, but it was a multi-center trial. They found drivers in both atria. I was interested in it because I wondered whether we'd find things in the right atrium that we hadn't approached before with ablation procedures. The increased number of drivers was associated with decreased success because those are the patients with longer standing atrial fibrillation. And as for how many people would actually have their arrhythmias terminate during the procedure, it depended on whether you just went after the drivers or you did a pulmonary vein isolation at the same time or whether you did some other things. Basically, the more tissue you ablate, the higher that conversion rate gets. It may be in some instances we're just debulking the atria. But 72% were AF-free after 1 or more ablations at 12 months, which is not bad for a group like this. Then there's another technology. This is the Topera system, which was developed by Sanjeev Narayan. Sanjeev was a fellow here. He's very, very smart, very articulate, and no matter what he says, it sounds pretty good. So, you know, he has a concept of fixed rotors that you could target and ablate, and most people are skeptical of this. And you put this basket up in the atria, and it's hard to steer, and it doesn't really have good contact with the walls, and it's distorted by the weird anatomy of the atria. So if you have a mathematical formula, it depends on interelectrode distance. It's not going to be quite the way it's supposed to be, and then you have to take you have this map that involves this signal kind of swirling around, which is very difficult to interpret. And so I said, well, we need some peyote to interpret this. So I called up Shandor and asked him how much. And 20 grams, he said, 20 grams. So you know, it isn't so easy to interpret these maps. And then you project them onto this three-dimensional image we create, and there's an error in that. So there are a lot of errors in the mechanism. But nonetheless, I think there may be something there. I've used it basically in the worst patients, and their outcomes are better than I would expect, but I haven't analyzed the data in any detail. There have been a couple other attempts to do this. Well, first of all, there's the data that Sanjeev Narayan came up with, which said it's great, except that most people are not able to reproduce that. And then Andrea Natali, who I knew he didn't really like the technology. He did a trial and showed that it was worthless. And when I got my email last night, that manuscript has been retracted because there were some irregularities in the way that study was conducted. So you can go to Jack and read it yourself if you want to. Then there is a trial that Johannes Brockmann has been running in Europe. It's based in Germany, called the Reaffirm trial, and this is another Topera type of trial. The enrollment is completed, but it'll take about a year to see what the impact is clinically. I think that trial will be conducted beyond reproach. So the conclusions I would draw from this are that mapping of atrial fibrillation substrate is feasible, though complex. It may involve repetitive wavelets. It may be stationary rotors. It may be some automaticity that we don't really know how to identify very well right now. Paroxysmal atrial fibrillation isn't the same as persistent atrial fibrillation, so as we develop strategies to do this, I think we'll approach them differently. And I think our expectations will have to be different. I don't think we're going to get equivalent results for the whole spectrum. There has been work, incidentally, at trying to quantify scar, and there is evidence that people with high scar burden based on MRI are less curable. Criticism of that study is it's a very proprietary technology to look at the scar. Not everybody can reproduce that. Our own radiologists are skeptical. But nonetheless, there may be merit in that, though it doesn't correlate linearly with the progression from paroxysmal to persistent atrial fibrillation. But we'll see how that goes. These technologies may improve. I've been critical of the Topera technology, but I think it's in its infancy and will get better. I've also been critical of the CardioInsight technology. It's a tricky system to interpret, but I think that will become more automated and will get better over time. And I think from this, if we better understand the physiology of electrophysiology, of atrial fibrillation, we have a chance to design more effective treatments for it and improve outcomes. Thank you.